So, good morning, ladies and gentlemen. Just to echo Anton's comments, it's a real pleasure, and I really mean this, a real privilege to be here with you today. Actually, having such a great group of patients in our audience today really is what we're all about, and I think will really help us to, from the professional point of view, help listen to what you want from us, and equally what we can provide for you. So I think we would all recognise that perhaps pain is the universal human experience. But pain varies considerably in that one man's pain can be another man's pleasure. Moreover, we also know that pain can also occur in the absence of ostensible injury. It really doesn't matter what branch of medicine that we practice. Each of these branches of medicine have their own chronic pain syndrome. Whether it's in urology with interstitial cystitis, in colorectal surgery with chronic pelvic pain syndrome, in pediatrics with what we'd term functional abdominal pain, in gastroenterology, irritable bowel syndrome, or indeed in gynecology with vulvodynia. Every medical speciality has one, and we often term these pain syndromes as functional. And I agree that this is not a very good term, but in the absence of anything else, this is what we're left with. So in terms of today's agenda, what I'm going to talk about is give you an introduction as to some of the chronic tummy pain syndromes. That'll be followed then with a basic roadmap of how the pain goes from your tummy up to your brain and back down again, and how sometimes that can go wrong and lead to some of the symptoms that many of you experience on a daily basis. We're going to look at some of the implications of the tummy pain, both on a personal and a more global level. Look at some of approaches and difficulties that we have as doctors providing care, and then a little bit about treatments, new treatments and treatment stratifications towards the end of my talk. So what about these implications of tummy pain? Well, I think you'd probably all say to me that the thing that probably drives you most to go and seek medical help is pain. We heard very eloquently from our first speaker today that urgency is also a very common symptom. But the literature and the data that has been published and that's out there suggests that pain is what drives you to go and seek help. And therefore, not surprisingly, it's a leading cause of healthcare utilisation around the world. In addition, tummy pain itself is the 6th most common cause for people to present to the emergency services. And I think you'd all agree again that it causes a considerable reduction in your quality of life. It's been estimated in 2008 that chronic abdominal pain costs over $12 billion in the 8 leading healthcare economies worldwide. So this exerts a significant social and economic burden to our society. What's the problems with chronic pain? Well, I think it is very challenging for us to treat. And that's really because we don't fully understand the mechanisms involved. I think many doctors think, with respect to chronic tummy pain, that we don't really have medications to treat it effectively. And hopefully you'll go away from my talk today knowing that actually we couldn't be further from that there are things that we can begin to treat tummy pain effectively with. The problem with many of these functional syndromes is that these are symptom-based diagnoses in the absence of a useful test. So we can't do an endoscopy, for example, and say, this is the diagnosis, this is IBS with constipation. An endoscopy or a colonoscopy, more accurately, will say that there isn't something else going on, but there isn't a test that we can request that's going to diagnose these symptoms, and that creates a number of problems. And even the venerable great and good in the field don't agree on what's causing the problem, and this has really delayed the advancement of effective treatments in these disorders. So a little bit of basic anatomy for you now. As we've mentioned already today, the gastrointestinal or digestive tract is one long tube from top to bottom with a lot of wiggly bits in the middle. But broadly speaking, it starts with the esophagus, your gullet, which runs through the middle of your chest, which then becomes your stomach, which then goes on to the small bowel, and then goes on to the large bowel, or what we term colon. Throughout the digestive tract, it has a very rich nerve and blood supply. Indeed, there are more nerves in the gastrointestinal tract than there are in your spinal cord. And these nerves actually detect a number of things, but one of them is what's inside the digestive tract. And what the nerves do is change that signal, that detection, into an electrical signal. That electrical signal from the digestive tract then travels to the spinal cord, and it then travels northbound into the brain. And the brain is a key component of this system because the brain, different areas of the brain detect different aspects of pain. So firstly, it needs to know where the pain is coming from, given by these areas here. It also needs to know how the pain makes you feel. How does pain make you feel? Well, some people get grumpy, some people get irritable, some people it stops them enjoying and doing the things that they love. And then finally, it's how you remember that pain. So you might think, well, actually last Wednesday when I was getting off the bus to go to work, I had excruciating pain. So it adds an emotional valence to the pain itself. And these are all distinct areas in the brain which all cross-talk with each other. But what goes up must come down. And this is a very simplified schematic of that process. So we're beginning to build a circuit here from the gut to the spinal cord to the brain. But also those signals come back to the gut to do something different. And those signals are transferred by a number of systems, but most notably the autonomic or the automatic nervous system. So this is the part of the nervous system that detects what's going on inside your body and largely runs in the background. Often you don't actually feel that it's going on, it's below your conscious awareness. But sometimes you might feel it. So when you're nervous, like I am now, my heart rate is up, my hands are a little bit sweaty. And actually, but more often than not, it's going on in the background, just taking care of everything rumbling along. And there's two branches to the autonomic nervous system, the sympathetic branch and the parasympathetic branch. And when we think of the parasympathetic branch, that generally acts as an accelerant in the gut. So it makes things go quicker in the gut. There's also a gland in the brain called the pituitary gland, which secretes a number of hormones. Hormones are biologically active substances, which in this case, this particular hormone can act on the adrenal glands, really to produce the stress response. And this system is what we term bidirectional. So there's a part that goes down to the gut, but also a part that goes back to the brain. And we know from a lot of research studies that personality, so whether you're an anxious person or an extrovert or indeed neurotic, this can also change this axis. But we also know that there's some genes involved in here, so the genes that you get from your mothers and fathers. So as I mentioned, this system is intimately involved in perceiving what's going on inside, and it's been implicated in many chronic pain syndromes, most notably irritable bowel syndrome. And not surprisingly, there's been a lot of effort, both from the academic community, but also the pharmaceutical industry, in producing and developing new drugs and new treatments directed at changing some or all of this system in one way or another. But what happens when it all goes wrong? Well, disruption or problems occurring at any level of that circuit can lead to changes in perception, and this may in turn lead to chronic tummy pain. So symptoms that your internal state that you hadn't felt before, suddenly following, for example, an episode of deli belly or gastroenteritis, actually can change and wind up that signal so that you begin to interpret that signal as pain rather than it just being the internal normal workings of what's going on. And this can lead to something called visceral hypersensitivity. So this is really when your insides are what we call, or what I term, sunburnt. The best way to describe that really is if you think about when you have your shower in the morning. The hot water feels quite nice on the back of your legs. But imagine now you've been on holiday and you've sunburnt the back of your legs. Even a cold shower now is absolute agony. So in terms of the stimulus there, i.e. the shower water, it produces two very different experiences. On one end it's reasonably pleasurable, but on the other it causes severe pain. And certainly infections and traumatic life events can actually do the same to your insides as well. And this concept of visceral hypersensitivity is really the leading hypothesis or idea in explaining why chronic tummy pain occurs. And it may alter transmission of nerve signals at any level of that brain-gut axis, whether it's in the digestive tract, in the spinal cord, or indeed in the brain. So if we think about visceral hypersensitivity, how do people doing research measure this phenomenon? Well, if you imagine the colon or the large bowel here, and then drill down to the rectum. So the rectum can be best regarded really as a storage container which stores stool until you are ready to evacuate it. And what researchers do, and don't be too shocked by this, it's pretty safe, is insert a balloon into the rectum and inflate the balloon. And some real seminal work from our colleagues in Chapel Hill in North Carolina, this is an old paper now, showed that if you blow a balloon up in normal people, here denoted by the red line, you have to blow in quite a large volume of air to be able to induce pain. But when you compare that to patients with irritable bowel syndrome, actually they report pain, here, shown here in the blue line, at much lower volumes, suggesting that their rectum, or their colon in this case, actually is much more sensitive to distension. And this was really the first study really to show this concept in patients with irritable bowel syndrome. So they have a heightened pain sensitivity. But as we've alluded to before, how can we manage patients with chronic pain well? Well, I think it is a real challenge, and I think right from the start we have to, as clinicians, acknowledge that fact. We've also discussed that it's a Cinderella speciality, that it's the icing on the cake. It's not cancer. It's nothing serious. Our patients aren't dying from it. Well, I would argue very strongly indeed that nothing could be further from the truth. Sure, it's not cancer, but in fact it has a huge negative impact on patients' quality of life. So we should take it seriously. I think one of the other problems is there aren't really a set of guidelines or a recipe that doctors can follow, because we are all different. Patients are all individuals, and trying to follow a flow chart of I do this and then I do that and then I do that is very difficult. But I would like to highlight some of the, in my view, some of the important principles in managing patients with chronic tummy pain. I think the relationship between the doctor and the patient is absolutely key in improving outcomes. I think all too often this relationship breaks down. If our patients don't trust us as doctors, it doesn't matter what drug or what intervention we give them, it's not going to work. And actually, rather than it being a doctor-patient relationship, I think it needs to be a doctor-patient partnership. I think as doctors, we're not omnipotent, and we can't manage patients with chronic pain on our own. I think first and foremost, you need a doctor who's interested in it. I'm sure many of you have been fobbed off felt fobbed off by doctors that you've seen in the past. A psychiatrist can often help, as can a psychologist or a therapist, and indeed a specialist nurse as a point of contact. And this multidisciplinary team really can improve outcomes. I think events like this are extremely important in helping educate our patients as to why they're getting pain. The politicians always say that knowledge is power, and I think this is the absolute example of this. And I also think we need to really agree treatment goals. I think you'd all recognise that Rome wasn't built in a day. And in fact, many patients have suffered with chronic pain for many, many years, and we are not going to get patients like this better overnight. So agreeing those incremental steps, as long as you're moving forward, and there may be some times where there are a few steps back as well, but as long as we're moving forward, then that's the key thing. Now, my mother always said, don't use the F word in public or indeed in private, but I am today. And going back to this idea of functional, again, I don't think it's a very helpful term. But it's interesting, the response when you give a lecture like this to other doctors. Some doctors will raise their hands and think, fantastic, I want to know more about this. But also, many will fall asleep at the back and just not be interested. So there's a wide variety of responses from doctors themselves. So that goes back to my point earlier about having a doctor with a specialist interest. I think as doctors we also need to know what our patients' agenda are. So when you come to see me, what are your worries and concerns? And I'd just like to share some of these with you in no particular order, but some things that I think patients have or want to know when they come and see me. So the first and foremost on most patients' mind, do I have cancer? Do I have the big C word? And I think we've become much better, certainly over the last 10 years of discussing this. But this is one thing that's very important to our patients. My symptoms are worse. Am I crazy? Am I mad? Those blooming doctors think it's all in my head. Nothing works. I've tried every treatment. My bathroom cupboard at home is like a dispensary. There are so many drugs in there, none of them work. No one understands me, and I'm under stress. And I'm sure some of you here today will recognise some of these concerns. But I want to flip this on its head now and give you the story from the other side as well. So this is a young upcoming doctor who's actually my son. So the doctor thinks, wow, I've got a really difficult patient in front of me. What do? I know what I do need to do. I need to rule out any serious underlying disease. I also need to find out whether the patient's had any recent life stresses. You know what, if I'm not home by 5 o'clock on the dot, the wife's going to string me up. I've got a busy clinic, I've only got 10 minutes per patient, I need the patients in and out. And sometimes this just isn't realistic. In fact, sometimes actually we don't know what's going on. And in my view, that's okay, but I think we need to be honest about it. Are some of the symptoms psychological? Well, yes, I think they are. I don't think we're a digestive tract, a spinal cord or a brain. We're actually a whole human being. And to suggest that one doesn't affect the other, in my mind, is erroneous. And does the patient have a hidden agenda as well? Is there something that I need to discuss with them or actually ask them about that they're not going to volunteer for me? And I think we've had a lovely example earlier this morning that, in fact, sometimes you need to be very direct in your questioning, discuss the elephant in the room, because I think actually if you don't ask patients difficult symptoms, actually volunteering, something that you don't even discuss with your partner actually can be very difficult. So asking those symptoms of, have you had any accidents, that's not something a patient will always volunteer to you. So these are some comments that I have heard in my time of colleagues making. So one doctor's comment, it's nothing serious. I'll just do a few more tests just to make sure there's nothing going on. And many of you have had these tests and they're uncomfortable, they're painful, they're invasive, they're embarrassing. And some of these tests actually aren't helpful. Your symptoms are all due to stress. Yes, that may be so that they're exacerbated by stress, but they're probably not all due to stress on its own. Go away, live with it. I can't think of anything worse to say to a patient. The doctor themselves isn't living with it. That's a throwaway comment that I think we need to get rid of. Here are some other comments, and I'll let you read these yourself, but actually when the doctor's not sure of the diagnosis, when it actually may be really clear, we often retort to further tests. And just because a fancy test or a fancy scan is negative, it doesn't mean that there's nothing there. I think we have to remember that all our tests have a limited resolution. So for example, if you think 10 years ago when digital cameras first came onto the market, maybe the bee's knees then was 1 megapixel. Today, I don't know, is it 20, 25 megapixels? We also have to remember that our tests that we do have a limited resolution and they are not perfect. I think some of the difficulties we encounter with our patients is that patients often have these chronic unexplained symptoms. Patients get pretty hacked off with us, and I think quite understandably so. We get hacked off with our patients, so what do? More investigations. That suggests, in my mind, that actually we don't know what's going on, and in the patient's mind actually induces that little seed of doubt that actually there may be something life-threateningly serious going on here. Not surprisingly, patients have poor outcome to treatment and often get referred on to multiple physicians. A lady I saw in my clinic last week had seen 20 different gastroenterologists across the UK. That's remarkable and not a good use of resource. And the problem is this cycle keeps going and becomes even deeper. And how as doctors do we get round this? Well, I don't think there's a magic bullet, but I do think what we can give our patients is time, empathy, and acknowledgement of that the symptoms are real and that they're having an effect on their lives. In terms of therapeutic interventions, I'm not going to go into too much depth here, but many of the interventions that we use aren't rocket science, and they're really targeted at really dialing down that pain. And some of these interventions actually are very useful. Some of them are from other chronic pain syndromes, but certainly drugs, antidepressants such as amitriptyline can help, and newer drugs such as duloxetine. And really we're not using them to treat depression as such. We're using them really to dial down that pain, that visceral pain hypersensitivity. Psychological treatments I think are very useful. I think one of the problems we have certainly in London is getting access to those treatments, but it's also important, just as you would choose a brand carefully, I think you need to choose your therapist carefully, someone who has real experience in dealing with patients with chronic pain. There are newer drugs coming along. They've been used in other painful conditions such as pregabalin, and these can be very helpful. And I'm going to just mention the electroceuticals, which is a novel term, just towards the end. In terms of these electroceuticals, these are implantable devices which sit on the nerves, in this case sacral nerve stimulation, and essentially have a box not dissimilar to a pacemaker, which you may have heard of, and actually stimulate those nerves directly. But this is quite an invasive procedure. There are new technologies coming along, such as vagal nerve stimulation. So this is a stimulator which is applied to the skin on the neck and actually can stimulate the vagus nerve, which is one of the main branches of that autonomic or automatic nervous system. However, these treatments are some years from routine clinical practice, but research is going on to investigate them objectively and systematically. So I think, ladies and gentlemen, really, in conclusion, I hope I've convinced you today that tummy pain is extremely complex. The evidence thus far suggests that there is a very complex interaction between the gut, the spinal cord, and the brain, both going up, but also coming back down as well. I think this partnership between doctors and patients are really key to improving outcomes, and certainly novel treatment strategies are on the way. We'll skip these ones. So this is something I first heard at our Society of Gastroenterology annual meeting, and it's something I've really taken on board. We all advocate that our services should be patient-centred, but I would argue that in fact a revolution is really coming, and that the service of the future, the service of the next 10 to 20 years, actually has to be patient-driven. Safe to say, I'd just like to acknowledge the people who've helped me perform my research and the various funding bodies who pay the mortgage, so to speak. And I'd just like to leave you today with one final thought. Thank you very much.